good evening, depending where you are. I'm Ana Lucia Jacome, Senior Project Leader and Human Rights Expert at the Division for People and Social Inclusion at UNITAR. It's a pleasure to warmly welcome you all to the fourth event of our series entitled Access to Health and Social Care Services. Let me start by introducing you Mr. Alex Mejia, the Director of the Division for People and Social Inclusion, and the Director of the International Training Centers for Authorities and Leaders, CIFAL Global Network. Besides of his experience working at the UN, he has worked for years at the private and public sector, including as the Vice Minister of Economy of the Republic of Ecuador. He served as alternate governor to the International Monetary Fund, to the World Bank, and to the Inter-American Development Bank, as well as member of the Board of Directors of Ecuador's Central Bank. Please, dear Alex, the floor is yours.
Thank you very much, Ana Lucia. Welcome to you, dear participants. I salute you from the Palais des Nations in Geneva, Switzerland. It's our great privilege to be able to count with your presence. And before I properly share some welcome remarks, I would like to express our sincere appreciation to all the panelists that are with us today, representing outstanding institutions that you are going to hear very soon about. The topic, it's quite unique. Mainstreaming knowledge on aging has been the ulterior motive, but this one is particularly important, and if I may, allow me to focus on that. Bridging paths towards strengthening protection and participation. So, aging is becoming more and more, of course, a priority for society because of the changes on the demographic structure of most of our countries, the changing in actuarial processes and retirement schemes, the changes in the abilities that we have longer and longer, and this is, of course, to be commended. We live longer, we can contribute longer. But even though it's pretty obvious for us at the United Nations, the great value and the great opportunities that aging issues will bring to society as a whole, at the same time, we know that there is lack of capacity to understand these issues, to manage these issues, and to conduct the inclusivity that aging has to have, the empowerment that aging has to have. Elderly persons are a wealth of knowledge, experience, resources, and will. So it's, as I say, something that everyone is now talking about, but I regret to say, and perhaps I speak better just on behalf of my country. I come from Ecuador in South America. We are still not dealing with this problem. We are still not recognizing the opportunities. So using my own country, which is the only one that I can speak about publicly, I believe, when I issue some sort of judgment, I believe that the whole of the public sector, the whole of government, but also academia, the private sector, media, civil society as a whole, we still have a homework to do. And that's why we organize this series. We are very happy to invite you to this mainstreaming knowledge on aging with all these different sites and focuses that we have had. But today, let me go deeper. It's about access to health and social care services. Without proper access to health, without proper access to social care services, vulnerable populations, mostly elderly populations, will definitely suffer. And we won't realize the potential that we have as society. So these events have been designed for public officials. Many of you connected today from very many countries. Thank you for the time you're going to give us. For civil society as a whole, very many NGOs connected today. Beautiful always to see, particularly for national human rights institutions. When we speak to you out of Geneva, the base of the Human Rights Council, I can tell you that there is a humongous effort that the whole human rights apparatus is doing to actually call attention to the rights of an older person. And as most of you will know, the UN is already well in the way to debate and to see how to create a binding multilateral institution, a convention that will help us to deal with this problem on a planetary basis. We are using the example of the CRPD, the Convention of the Rights of the Persons with Disabilities, to hopefully create down the road, hopefully soon, perhaps 1-2 years, if not more, to create a conventions on the rights of the older persons. Professor Marcus Stein, which is with Harvard University, Harvard Law School, which is with us today and will speak later, it's a connoisseur, an expert, one of the leaders that participated in the creation, adoption, and enacting of the CRPD. So we're very happy to know that he's also willing to guide us, to guide the United Nations system and its member states towards now a global convention on the rights of older people. But beyond that, several other speakers that you will be very happy to enjoy, including a former Minister of Health of the Republic of Ecuador, a competitor of mine, Dr. Jimena Garzón, that will join us later, a colleague from WHO, a colleague on the aging and disability inclusion of, thank you very much, Ana Lucia. There you have it in front of us. And then, of course, all of them already connected. Dr. Zhang from WHO, Mr. Ricardo Pia Cordero, that I was just mentioning, that belongs to the Division of International Protection or Community-Based Protection Unit as well. Ms. Abdul Baki from Iraq, the High Commission for Human Rights. Dr. Sophie Mitra for Fordham University. Dr. Jody Heyman, former Dean of UCLA Fielding School of Public Health. Impressive array of speakers, all of them very much committed. And as I say, to wrap up, an old friend of ours, Dr. Michael Stein from Harvard Law School. So we have a lot to discuss. We have, of course, a big appetite from our audience, but these welcome remarks wouldn't be possible unless I tell you that we at UNITAR, the United Nations Institute for Training and Research, will remain committed to build capacity towards issues of aging, from the rights of older people to public policy behind issues of aging, and particularly today, and as always, access to health and social care services. Without good health coverage, no aging population can thrive. So let me finish there. Thank you again, dear participants, for joining us. And now we will have our moderator, Ms. Ana Lucia Jacome, taking the lead now. Thank you, Ana Lucia. Back to you.
Thank you, dear Alex. We would like to share a video message from Dr. Hubon Yang on behalf of the World Health Organization. As you know, the WHO is the UN entity with a mandate with leadership on health issues, including for the UN Decade of for Healthy Aging. Dr. Yang is medical officer responsible for long-term care at the Aging and Health Unit within the Department of Maternal, Newborn, Child, and Adolescent Health and Aging, the WHO headquarters in Geneva, Switzerland. Please, Rafael, play the video.
Good morning, good afternoon, good evening. My name is Hyobom Jang, medical officer working on long-term care at Aging and Health Unit, WHO headquarters in Geneva, Switzerland. Thank you so much for inviting me to this roundtable series on mainstreaming knowledge on aging. It is my pleasure to participate in this specific topic on access to health and social care services for the vulnerabilities emerging from aging. We, from WHO, as one of the leading agencies of UN Decade of Healthy Aging, would like to talk more about the health and care needs of older people for today's event. We all know that when people age, their health and care needs become chronic and complex. Unfortunately, we also know that our current health and care systems are not readily available or adequate to respond to older people's and families' diverse needs and multimorbidity. The current levels of unmet health and care needs among older people and their families are growing fast and concerning, and it is happening even faster in lower middle-income countries. There are identified gaps to hinder the rights to health and access to health and social care services for older people. Let me start with some concern about growing demand for care and unmet needs. On average, more than 30% of people aged 65 or over living in private households were in need of long-term care, according to some data in the EU. Although the numbers and statistics vary, between at least 10%, at most 50% of the people are estimated have at least one unmet care needs, even though they're having difficulties in their daily living. So there are many issues around health and care system which doesn't respond to these unmet care needs. The governance is not effective or efficient. Sometimes the governance are very complex, uncoordinated, and fragmented, especially between health and social care sectors and also between public and private sectors. The government should be more responsible and responsive, and they should lead and coordinate this care provision across multiple multi-sectoral entities and ministries. The financing is also one of the most common problems. Due to a wide perception that care for older people, ensuring their access to health and social care is too costly and will not be made sustainable in the future. The countries are not necessarily committing their budget to allocate to cover the access to health and social care for older people. So these service provisions are often underfunded by the public sector. We call for more universal coverage of health and social services for all the people, also to ensure the informal care is more funded and supported by the government. The provision of health and social care services is not integrated, but is more fragmented and uncoordinated. There are many gaps in services and access and quality uneven. Services do not adequately address the needs of older people and carers. Especially, it doesn't really recognize or respect their preferences of value and their wish to age in place. So, individual need, including those of carers, should be regularly assessed and described in person-centered care plans, and that should be addressed with integrated person-centered coordinated service provision across the continuum of care, from prevention, promotion, to rehabilitation and palliative care. The personal dignity and right should be ensured in providing these care services. Often, information about health and social care of individuals are lacking or fragmented. A person's health and social care needs and their status should be identified, assessed, and should be coordinated between different sectors. Not only older people's, but also carers' needs should be identified, monitored, and supported. There's huge issues around informal care in every part of the world. So-called informal, unpaid, or family caregivers provide most of the care for older people, which is not really recognized or measured or supported. The workforce issues, especially on the informal carers, these are hugely prominent in most of the countries. There are not enough formally trained or paid care workers to provide adequate health and social services to growing population of older people. And still, most care services depend on unpaid carers who are mostly women or family members or volunteers in communities without formal training, support, or recognition. As a result, those family unpaid informal carers are often overburdened, and this leads to their burnout and inadequate care, also resulting in their physical and mental distress. Those unpaid informal carers, as well as former and paid care workers, should be able to receive adequate training and receive support from the governance authorities, and their job conditions and decent working environment should be also ensured for adequate skilled workforce and service provision. How the countries can move forward this issue to provide the right to access health and social care services. One of the first steps would be to recognize all the people and their carers as one of the priority and focus policy target populations. It should be recognized and mainstreamed and legitimated in a standalone or as part of national level key policies or legislations. There should be also a dedicated and coordinated and responsible government body or focal point to be in charge in regulation, legislation, and also the implementation from national to subnational levels. Having more universal, comprehensive, and publicly led financing schemes and coverage schemes to ensure access to health and social care services without financial hardship is one of the key. There should be also comprehensive assessment of the needs of older people and their carers, which should be matched and followed by the adequate person-centered health and social services. The care workforce, including informal unpaid family care, should be able to receive adequate capacity building opportunities, job conditions, their career plans, and with also adequate support to address their own needs and stress. Although this is not easy to address at the same time, many countries are trying to solve these issues by their own legislation, national strategy, policies, or grassroots programs interacting with older people and carers. I urge all member states and UN agencies and relevant stakeholders partners to pay the attention and provide support to the WHO's effort and the frontline health and social care workers to provide adequate service for all the people and their carers. Thank you so much for your attention.
Thanks, Rafael. To continue, it's a pleasure to introduce our dear colleague, Mr. Ricardo Pla Cordero. He works as Protection Officer at the Division of International Protection at the United Nations High Commissioner for Refugees, where he provides technical support on the rights of persons with disabilities and older persons under UNHCR's mandate, which includes refugees, asylum seekers, returnees, internally displaced, and persons in situations of statelessness. As a development and humanitarian worker, Ricardo has experience in the design, implementation, and monitoring of human rights programming and in the development of policy and guidance on the rights of persons with disabilities and older persons in situations of conflict and disasters. Please, Ricardo, the floor is yours.
Thank you so much, Ana Lucia, and it is a pleasure being here. I'm going to share quickly my slides. I think you're seeing that, yes. The focus of my presentation will be on how the situations that Dr. Zhang has shared on the impact of poor health and social protection systems having a particular situation or group of older persons living in situations of forced displacement. That means refugees, asylum seekers, returnees, but as well internally displaced persons. And then older people without a nationality or in situations of statelessness. In the screen, we can see some of the policies that guide UNHCR work in this regard, and including as well the strategy, the latest global public strategy, which has specific provisions for older persons, and as well giving an idea of the volume of population we are talking about, 4% of the 108 million who are forcibly displaced worldwide. Considering that this is already somehow outdated and that the prevalence should be higher as well. Data disaggregated by older age is not very often made available by states as well in charge of registration. So in terms of challenges, we see that first, when people are forced to flee, they may lack documents. They may lack documents to leave their country, traveling documents, passports, etc. So older persons remain in their countries or in situations of danger more than other populations. But then when they flee, they may have lack of access to this type of documents or other documents that may allow them accessing national services. Of course, there is a separation from community support networks, which heighten the risk of violence, of abuse, and as well when they are accessing or trying to access their own benefits, they may see that they are not able to connect with the systems or the benefits they may be receiving in their countries. Of course, medication may be in other languages, may be lost. They may the prescriptions may be as well not comparable to those of countries of the host countries. They may lose assistive devices, and they may face a lot of difficulties in accessing information in other languages or in a world that is progressively being digitalized. And we see this trend in humanitarian aid as well. Finally, the psychological toll of displacement is more challenging, or we find it more challenging in older persons. And we will see this in some statistics that are extracted from our annual public health global report. The first one we see is causes of mortality by age, and we see that older populations over 60 years old, and we see already that would be feedback that I have shared with our colleagues. It would be interesting to have those disaggregated by 60 to 70, 70 and 80 plus. But we see already that those cardiovascular diseases, lower respiratory infections are an anemia, but in a lower percentage are those leading causes of mortality. There is a coherence as well with the chronic, the impact of chronic diseases by age. We see hypertension, so would be related as well to the mortality cause as one of the first leading chronic diseases by older persons, and as well diabetes in a second position. Just clarifying as well, I jumped directly to statistics. These statistics you can check in the report, but they are coming from a population of approximately 5 million refugees in across 172 refugee camps in different regions of the world. So they are a quite representative sample. In terms of response, well, the fact that they were already accessing these services and that we have this data is a sign of access. There were around 10 million consultations directly provided by UNHCR last year, but room for improvement. Is difficult to access exactly how many older persons were accessing those consultations. We know that they were because of the reports and the results, but it's a little bit challenging to know exactly those numbers. And this is another recommendation I shared with my colleagues. And now what we have is mental health. So the toll of mental health that I was sharing before, this is very small, I acknowledge, but I will just interpret. So the deep blue and the light blue colors are representing 60 years female and male. And we see that in correlation what we saw as well in terms of anecdotic findings on the toll of mental in the mental health of older persons that displacements may have, that depression and psychosis, mania are those with a higher prevalence of older persons reporting that, including as well other psychological complaints. It is something that we witness, and when we are in consultations, we see that older persons tend to feel more disoriented in situations of displacement. Now to close, what are some of the enabling actions that we can put in place? So, well, improving access to or a knowledge of monitoring who is accessing to what, who is not accessing to which services, and ensuring that older persons have a say in what we are programming, um, that there is a higher awareness in health providers, in particular in emergency settings as well, on what are the key requirements of older persons, avoiding as well ableist attitudes across health systems and health service providers, ensuring accessibility of information premises, but as well alternative ways to facilitate access. Outreach support is very recommended and is very often used by UNHCR. And then, of course, accessing national services. Now, there are some urgent gaps that we have seen, and I would like to close with this. First, there is a rights-based or a need to embed a rights-based approach into support systems. As Dr. Young was highlighting, we have an overall presence of informal work in terms of support and care. And there is an opportunity of by establishing a link with gender equality agenda. We see many times that gender equality requires time for women to access education, to access employment, and that time is absorbed by care obligations. If those agendas could come together and we could be asking for a rights-based support system that is professionalized, that is uptaken by the government, as a way as well of promoting access to employment and education and equality for women, probably the message would be more powerful. And the last problem, that is these three bullet points there, is the absence of a case management system that is able to answer to situations of elder abuse. So older persons who are experiencing violence, neglect, abuse in their homes or their communities will not have a case management system that is adequate for them. We may see, for example, child protection services, GBV services, gender-based violence services, but those are very strong pillars in humanitarian and development situations, but we don't see that much of a third pillar supporting situations of elder abuse, abuse against persons with disabilities, and other profiles that are not within those two pillars. There are some examples with NGOs leading on this, and we have a program Safe at Home with IRC, etc. But still, there's room for improvement, and in particular, having a transitional model that can make countries or states more responsible for that. What are the venues? Well, we have the Global Compact on Refugee coming in less than a month, and there are pledges that particularly focus on national health systems, mental health, and economic inclusion and social protection. With this, I would like to finish my presentation, inviting you to check the Global Compact website and see how your agencies or efforts could contribute to this joint effort. Thanks.
Thank you very much, dear Ricardo. It's always a pleasure to hear you. We truly commend your efforts. UNHCR is quite active, and we truly hope you get all the support you need, especially in these sensitive moments that we are seeing around the world. We appreciate that you have highlighted the importance of the indicators and monitoring to take stock on the situation of older persons as a step to move forward. We will revert to you with some questions in this regard. Now, I have the pleasure to introduce Madame Nisrim Abdulali Abdul Baki. My apologies, please, for the pronunciation. She is an international trainer responsible for programs in the Publishing and Education Department at the High Commission for Human Rights in Iraq. Her work is on human rights and national human rights institutions. Please, Nisrim, the floor is yours.
Thank you. Thank you. Good morning, good evening, good afternoon for all in this session. I would like to thanks to give me this opportunity to be a speaker with other experts and other colleagues in this session. First of all, I want to introduce or make introduction about the nature of international conventions. And we know all that the international conventions effective role in providing protection to all kinds of human and consider as a woman, a child, disabilities, and other groups of human beings. But the category of which it came, in fact, the group of older person face a big neglected and a problem in all the world because they're aging. They face not care from the government or not only the government, not neglected from the society. First of all, this affected by the awareness of this society. Sometimes the picture of poverty, all these face this problem. Anyhow, recently there is a special draft agreement or convention for the old person. It's make as a draft. We speak about this and this discussion, this draft before 2 months in Philippines, I think. And when there is exist like convention, it must provide at least the protection through international laws that oblige the country to take care a suitable measurement regarding the old person. This means the society and all monitoring bodies must take a big role and effective role in this convention. Therefore, today why we need like this international convention or agreement to emphasize that the right of the older persons and to establish a system for monitoring how the convention is playing or implementation in the world. So the issue of state and everything related to the situation of them. So it's necessary to know all the rights through the international and national legal system and to determine what the rights of them, especially we speak about the element about the health and social care service. And the convention, international and national laws, I speak about the international standard. Here in Iraq, we are, in terms of commitment of right, we are a country regulated to International Convention of Human Rights, like the Conference of Economic, Social, and Cultural Rights. We ratify on the Convention of CEDAW, also Convention of the Child and the Convention to protect the disabilities person. And the level of national standard, the constitutionally guaranteeing the right of the health for all citizens. In Iraq law, all person defined as anyone who has reached the age of 60. According to the Unfilled Retirement Law number 9 in 2014, which set the legal retirement in age of 60, this number of the age limit, the government responsibility about this special group, the old person. But this law not make the protection to other unemployed old person. Speak about the person who is working in the government institution. not take care to other people who is working in the private sector, or maybe have no job or work to get the salary. But we, as a monitoring national institution, the High Commission of Human Rights in Iraq, we indicate several points about that. First, we speak about the legislative. We like to a clear law protecting them and mending them to be in alliance with the international standard mentioned in Convention of Human Rights value, as we know. Then challenges and the barriers, and we speak about the obstacles. We need to specific health guarantee law to protect the rights of the older person and barriers in itself, preventing the guarantees of respecting their rights. Additionally, the legal system, as previously the discussion indicate, to lay to the sufficient attention to policy make the field of all person rights and their access to the health care service and other rights. Second, how the old person enjoying the rights. The old person face a huge negative practice that reduce or sometimes cut their rights and hinder their to access to the service, lead to financial and human resource, which negative affect their enjoyment of the right to the healthcare and service. Additionally, healthcare for them should be improved and comprehensive. A program should be implemented to provide a supportive environment and assistive device in the public facilitated and recreational area can handle the mobility and integration in society. Care, it means their ability to obtain the health care, to help them maintain or restore the standard of health care, a healthy environment, and prevent the disease or a chronic disease. It is important to create environment that is accessible for older person by providing supportive device in all the fields of life. We need to electronic medical records can improve healthcare. Recording contains information about the person's health and to keep digitally enable of healthcare practicing the responsibility for the person care to access a cure to the data, legible and complete information about the person whenever they need to use. Electronic medicine record typically contain demographic and personal information such as the age, weight, name, her address, person medical history, including vital signs, medication, and the person carefully taken immunity situ and other. And the result of examination and testing, whatever a clinic, laboratory, or radiologically, billing and facilitating information. As well as healthcare remains have challenges for them to access to the highest level of health program and strategic. The action plan should be implemented to protect them health so they can access easily to the service. Providing health and service environment for the older person and the right to obtain service and healthcare align with respect their human dignity according to the application of element of the right to the health that the committee on the covenant of the right, the economic and social and cultural rights. The element of the health rights, it's available. It must be available, and accessibility. It means it's accept from all, and it's easy to reach or easy to access to the service, and it's a quality and share and accountability. We faces on the accountability to following and updating and monitoring how it's the service provide to the older person. Finally, I speak about the unequal between on a gender between women and a man. The women here in our society have this discrimination to be at the same line to the man, because the culture of society, and they look to the woman always in a second degree. The women have many upsets. First of all, she's a woman. It's the first abuse. The second, when she's begun eager or old women. Third, if it's suffering from the poverty. Fourth, if it's have no source to live. Fifth, if the laws of the country not to protect this group of person, so that the old person really in a big problem if there is no a real mechanism to cover or to provide them to the protection they can live in dignity way. Thank you.
Thank you very much, Nisreen, for your presentation. We truly appreciate the participation of national human rights institutions in the framework of this series. And we hope that you can join us in the last event of the series next month.
Thank you.
Now, we are going to learn from Dr. Sophie Mitra. She's founding director of the Research Consortium on Disability at Fordham University in New York City, and principal investigator of the Disability Data Initiative. Her research agenda has documented economic insecurity and identified policies that reduce it. A line of work consists in evaluating the impact of social protection policies on well-being and health, with a particular focus currently on long-term care insurance. Another line of work has produced evidence to document disability inequalities and to understand the factors that drive them, such as discrimination or extra costs of living for families. Please, Dr. Mitra, the floor is yours.
Yeah, thank you so much, Ana Lucia, for your introduction, and thank you for having me. I'm going to share my screen. I have a few slides. Okay, can you see my screen?
Yes.
Oh, okay, great. All right. Okay, so I will be speaking about access to health and social services and economic insecurity, and trying to learn lessons from two recent studies we did with several collaborators, studies on China and on Korea. So the first study is on the economic and health effects of long-term care insurance in Korea. And it's a joint study with Professor Hulda Kim of Black Hills State University. So you have the link to the article, if that's of interest. If we can share the link to the article, Ana Lucia, that would be great. So as it was mentioned earlier, long-term care insurance is a very important policy issue in aging societies around the world. And we need to understand the consequences of long-term care insurance programs, if they are working, if they are effective, they can be made more efficient, if they allow access to care services and so on. And yet we have little evidence on the impact of long-term care insurance policies on individuals and on households. So we focused on the case of Korea. Korea is a country that is aging and has had a long-term care insurance program in place since 2008. So we have this relatively recent program, and it affects all Koreans, older Koreans and Koreans with chronic health conditions or disabilities. And the eligibility test is to have a physical and mental health status check and to be in need of care. The program covers home-based care as well as institutional care. It comes with co-payments for beneficiaries, 15% for home care and 20% for institutional care. So the question we try to ask is, what is the effect of Korea's long-term insurance program on health, on healthcare utilization, as well as on economic security, which we measure by taking a look at the savings, household savings, as well as how they spend their money, if they have any change in expenditures on food, housing, and other important expenses. So we use panel data. We're able to track households over time from before the time the program was put in place, so from 2006 until recently in 2019. So we have close to 4,000 households we can track over time that have at least one older adult. And we have a treatment group where we have some beneficiaries of long-term care insurance and a control group, so households without beneficiaries. So just to highlight the key results, we found, well, first that beneficiaries tend to have better self-rated health than non-beneficiaries. So our results suggest that there is a positive effect of the long-term care insurance program on individuals, and in particular on individuals that have continuously used the long-term care services, in contrast with individuals who might have used services some of the time, but perhaps discontinued the services other times. We found that the program seems to affect the utilization of healthcare services, with overall an increase in healthcare services utilization, but a decrease in number of outpatient visits and an increase in the days of hospitalization. So healthcare services are impacted by long-term care insurance, and with overall an increased use. In terms of economic security, we find that beneficiary households tend to spend less money on necessity items such as food, but spend more money on healthcare services. And at the same time, we find that beneficiary households tend to have lower savings than non-beneficiary households. So these two results suggest that there might be an unintended effect of the long-term care insurance program in the economic realm, with lower savings and perhaps lower expenditures on key items such as food, which is cause for concern, but might be. And we found that this result was particularly pronounced for disadvantaged groups such as older singles and poor households, and also for persons with less comprehensive health insurance program coverage. So that suggests that when we evaluate a long-term care program, of course we want to evaluate its impact on the care of the beneficiaries that the beneficiaries receive and their health and well-being, but we also want to consider potential unintended effects on economic insecurity due to the co-payments that the care services might entail. The second study I wanted to highlight is jointly authored with Hulda Kim again and Jingyi Gao of Fordham University. And it's on out-of-pocket health expenditures associated with health conditions and disability among middle-aged and older adults in China. So why China? China is a very interesting context to study for middle-aged and older adults, as there was a considerable expansion of health insurance coverage in the in the years 2000s and early 2010s. So now there are several health insurance programs in place in rural and urban areas, so that older Chinese people tend to have at least a basic health insurance coverage. So in that context, what are the out-of-pocket health expenditures of older individuals, and who are the individuals that are at risk of high out-of-pocket health expenditures? So briefly, we find significantly higher out-of-pocket health expenditures. So in other words, health expenditures that are not covered by health insurance. So higher health expenditures among older persons age 70 and above compared to persons age 45 to 69. We find higher out-of-pocket health expenditures among women, among persons with disabilities, and among persons with multimorbidity. So that suggests that even when we have health insurance programs in place that tend to be very widely available, there could be economic insecurity associated with accessing care, even in such a context. So to wrap up, I would argue that it's essential to assess the impacts of programs that provide care services and may have unintended effects on the economic security of older people. There's a need to monitor economic security for older persons, including through intersectional analysis, where we combine age with gender, with rural-urban residents, and with disability status. And we have a growing availability of data on functional difficulty to measure disability in national household surveys and censuses that offers opportunities to do such intersectional analysis. And recently, as part of the Disability Data Initiative, we started to do some of this analysis. The analysis of older persons' economic security can be part of a documentation of the human rights situation of older individuals and can help inform care policies and programs. Thank you so much.
Thank you very much, Dr. Mitra, for sharing some important highlights on the importance of autonomy for older persons. The issue of economic security is quite important and usually is not considered by authorities as part of their priorities. So it's important to make visible the efforts from academia in coordination with other partners, as you have done the research in your publications. Now, let me continue with a well-known expert on health, Dr. Jody Hyman, Distinguished Professor of Public Health of the University of California, Los Angeles, UCLA. She's founded director of the World Policy Analysis Center. She has served as Dean of the Fielding School of Public Health from 2013 till 2018. She leads an unprecedented effort to improve the level and quality of comparative policy data available to policymakers, researchers, and the public sector. This initiative examines health and social policies and outcomes in all 193 UN countries. She has authored and edited more than 500 publications, including 19 books. Please, Dr. Heyman, the floor is yours.
Thank you so much. It's a joy to be here with you and with everyone. I am going to share some slides. Okay. Let me first just change the dialogue a little bit by using a term that I think a number of us could as speakers, but I think collectively gets lost, which is the term we. So not all of us are older people, but some of us by these definitions, including me, are. And I think society does so much to hide the visibility of the diversity of older people, the engagement of older people, and following in, I think, the amazing footsteps of the CRPD, which really had such power around voice. I do think it's important that we bring that voice of agency, of the diversity of who's affected to these discussions. So the main thing I'm going to talk about when I present slides is that while the we of older people is a diverse group in health needs, a diverse group in stage of lives, in economics, in geography, I think agency, participation, and engagement are a commonality across these, across locations, across geographies, and across health status. Most older people around the world do two things that I'll focus on today, but there are many areas we could. Most work and most provide care as well as receive care. That work looks different. Sometimes it's for wages, sometimes it's for cash, sometimes it's supporting family enterprises or work, sometimes it's for in-kind. But it's a minority that are not working in some way that affects economic productivity. And most not only receive care, but most provide care. So I think we have to think about this whole set of lives when we're thinking about what it means for healthy aging. Supporting the work and care of people who are aging, I think, is essential to the health of all of us collectively who are aging, but it is also essential to the health of families, communities, and countries. So I'm going to go through some policies now, because one of the things I've enjoyed watching in the chat, and I'm sure there are others who it's on their mind but haven't entered the chat yet, is what can we do about it? What can countries and companies do? And since we're talking in a UN forum and talking about international agreements, I'm going to focus on what countries can do. Clearly, they need to be active across many areas, but I hope to at least illustrate an approach that matters into care and health and work and health. Just as a moment of background, I direct something called the World Policy Analysis Center. Everything I share is freely available in 6 UN languages, freely downloadable at worldpolicycenter.org. And that's because of a philosophy that we believe all of us need to know what our countries are doing, how it compares to other countries, what are successes out there that can be emulated. And we need to learn what works and partner for accelerating change in ensuring everybody has access to what's needed. Okay, I mentioned that most people work and care, receive care and provide care. So the first example I'm going to talk about is, what's it mean to need to receive care? We've talked already a lot about the health system, but receiving care is about more than the health system. Is somebody able to support an older person who's sick when they're in the hospital, support them when they transition home, support them in rehabilitation efforts? If they need higher levels of care, support them in that transition. Well, that may well be done by a working age child. So does that child, this is thinking of older persons who need to receive care, can their children take leave from work to provide that support? There's lots of evidence that's essential. Yet most of the world does not provide any leave to care for an aging parent. So that's 78% of the world doesn't provide at least 2 weeks. And as you can see, every country that's red, there's no guarantee. That's even in the formal economy. It would be less in the informal economy. Now, we should worry as well about whether or not you can take leave for a spouse. Now I'm talking about people as they age, who are likely, again, all of us live as multifaceted human beings engaged in many aspects of life. Older individuals who are working are likely to be, if they are partnered, are likely to have a spouse or partner who is also older. Can they take leave from work to provide that care? And here too, you can see most countries, the majority of countries, that's true in high income settings as well as low income settings. The majority of, even though more high income countries provide this leave, it's still less than half. And in some groups like middle income countries, it's just 16% provide at least 2 weeks of leave. So this is an enormous gap. If an individual gets cancer, if they have a stroke, if they need family care. Clearly, the health and social service systems cannot supplant the care of families fully. They can't afford to, and it's not the same quality of care as family members. It's a crucial element, but it needs to be done in partnership with families doing care. This just sort of summarizes the overall who gets paid leave, and I think it separates the dark blue if you get that leave if you're living in the household with a person, and the light blue if they're living outside the household. And it shows two things. One, countries are less likely to give it for you to care for a parent, a grandparent, a partner who is outside the household, a sibling. But across countries, the majority of people are not getting this basic leave, and the numbers would be even smaller if we looked at the informal economy. Now, I began this by talking about agency and the fact that most older people work in different aspects of life, work in different ways, different sectors of the economy. That is fundamental to health. Our data is massive that older individuals who stay engaged, civically participating, working, stay active, are more likely to be healthy in the first place, not in a causal direction. Staying engaged reduces the onset of new health problems. So this is a fundamental issue to health. It also provides support networks and resources that matter to addressing health. Now, one would think globally then, we need to take the basic step that people who would like to work can. This in no way prevents ensuring that there's a pension for those who are ready to retire. So how much is discrimination allowed in all aspects of work? That means how many countries protect against discrimination in hiring, promotion, training, firing. And you can see it's actually a minority of countries that prohibit age discrimination. In fact, in hiring, only 47%, prevent it in pay, only 46% prevent discrimination. And when it comes to things, I'm going to then go on to termination. Are people allowed to be fired just based on their age? In 3/4 of countries, they can. There's no reason for this. Countries can have across the board, can have pensionable ages and still not allow discrimination that mandates, that allows firing at a specific age. So the piece I want to conclude with, just with those two examples, is two thoughts. One is most people have agency participation across the life course. This includes people with cognitive impairments at end of life who still exercise agency and want to have decision-making about health. This includes across the older care spectrum, age spectrum, people who are working and providing care full-time, part-time, for money and for not. So we need to think about, we need to really consider that in all of our policies and in the agreements. And then as an approach, that's the second thought I'd like to leave everyone with. If we really want to accelerate action, we need to start holding countries accountable for the national steps they're taking at scale. A global agreement is a terrific way to do that, but then we need to look at what is happening at a national level. Are these fundamental steps being taken? Make the availability of solutions that work widely recognizable, and make what steps are present and absent visible so we can make progress. Thank you very much.
Thank you very much, Dr. Heidman, for highlighting the importance of accountability and redress as well. That's why a number of stakeholders have been promoting the existence of a legally binding instrument to strengthen the norms for protecting and for promoting the participation of older persons in different aspects, not just on health issues, but also in a wide range of issues. Now, last but not least, of course, for analyzing the legal gaps at international level on the access to health and social care services for older persons, I have the pleasure to welcome back Professor Michael Stein. He's the co-founder and executive director of the Harvard Law School Project on Disability. As you know, he's considered as one of the world's leading experts on disability law and policy. He participated in the draft of the UN Convention on the Rights of Persons with Disabilities, and he has been with us since the very beginning of this series. So we are quite honored to have you here again, Dr. Stein. Please, the floor is yours.
Thank you very much, Ana Lucia. It's delightful to be here. And of course, it's an honor for myself and for the Harvard Law School Project on Disability to be one of the co-sponsors and supporters. The panelists were marvelous, and I know quite a few of them quite a while, and they're difficult to follow. But I thought I would just touch on a few issues as I usually do. One is that one of the rationales and justifications for having a specialized treaty for the rights of older persons parallels that of having a specialized treaty for the rights of persons with disabilities, and that is under the existing UN treaty system, under the existing UN programming, Although older persons or persons with disabilities, and I note that the two categories overlap significantly at times, were not addressed. The reason that we have a specialized disability treaty was to shine a light on and to try to ensure that people with disabilities were included, whereas they were not under universal, quote unquote, coverage, whether it was the Universal Declaration or whether it was the other identity treaties. In this case, just to pick up one issue, we have Article 19 in the CRPD on independent living and living in the community. And the reason that we have that article, which does not appear in any other human rights treaty, is because of the history of people with disabilities being segregated, being placed into congregate settings. Very often these rose to a level of torture, inhumane treatment, as Juan Mendez and Manfred Novak pointed out in separate reports, and not allowed to be part of their communities. I would suggest that here, in the context of older persons, we have in many ways a similar situation in that in much of the world, people who are elders wish to remain at home for as long as possible. And in many places, they're fortunate to be supported by their families and at times by their governments. But especially in middle and high income countries, as they have industrialized, as they have become wealthier, and as the middle generations have gone to work, there's been a shift towards congregate care as well. Sometimes the euphemisms are nursing homes or golden age opportunities or daycare centers. But the fact of the matter is these are not nice places. They often are subject to abuse. The healthcare that is provided is minimal. And as we saw during COVID, large swaths of these populations in these places simply died because they were so far down the priority list of receiving care. And I'm concerned that for older persons, we have not had a deinstitutionalization movement as we have had and continue to have for persons with disabilities, especially persons with intellectual, cognitive, and psychosocial disabilities. And the temptation for middle and high income countries is to treat individuals in the most efficient way. We now seem to be in the neoclassical world of efficiency, and to do that means putting individuals into large care settings. And so far, there has not been a voice against that, or a very loud voice for the right to live at home, age at home, have dignity, and stay at home. And this is one of the large issues that a treaty for older persons will need to address and can make a lot of progress in highlighting and addressing. I also want to point out that the issues of food insecurity and medical care are likewise major issues for older persons and can force them into congregate care when there are not other opportunities, either at home, even with wonderful and supportive family, to receive adequate care or adequate food. We are in a world now that is facing increased food insecurity, water shortages, and so on. And it may be the case that older persons are encouraged to enter into these larger congregate care settings, much as parents of infants and children with disabilities were encouraged to place them in those settings on the notion of it's the only way that they can receive the support that they need. We know that food can be delivered, although it is always resource dependent. And we know that as far as receiving healthcare, just basic access to it, persons with disabilities, persons who are older people, and the population that overlaps, which is significant, are often last on the list. We saw this during the COVID crisis. We continue to see it after COVID. We saw it during the crisis standards of care, deciding who would receive care first, largely based upon factors including the life expectancy after treatment, which may be a neutral criteria, and it may be a scientifically derivable number, but it's going to discriminate and put older persons and often people with disabilities at the low end of the stick. And there's also the unwritten stigma and assumptions that go into healthcare provision that are not written down as formal standards as to why should we help these group of individuals. They've had their lives, they're older. We should focus on others. One aspect that I'd like to highlight that I didn't hear very much about is the notion of loneliness and its impact upon mental health. We know that the UK now has a minister on loneliness, but it's one of the social determinants of poor health when people are isolated, both mental health and physical health. I think we should also highlight the impact of gender on older persons. Women live longer than men. And again, that interrelates not only to how much care they will need, what type of care they will need, but also the linkages to loneliness and mental health. There are some good prospects. Telehealth, in theory, can provide opportunities for some older adults to receive care at home and minimize the requirement to move or to go somewhere to receive help. But of course, that also assumes access to and familiarity with technology, and both of those can form a barrier. I wonder, as we move forward in this not so brave but certainly new world, what the role of artificial intelligence can play in a positive manner. There are lots of reasons to be fearful of AI, but I also wonder if there are positive usages that could be used to help support people who are living at home, have difficulty transporting themselves to medical care, and so on. Last, I'd like to remind us that while we are speaking about state-based obligations when we speak about a treaty, we also should think about state as supporting or deriving by itself community-based options and support, including family, culturally and socially appropriate ways to help support both the provision of healthcare, whether it's barefoot doctors or otherwise, and food security and other social services. Dr. Mitra had spoken a little bit about China from an empirical point of view. From a more anecdotal point of view, one scholar friend who's worked there for about 60 years has told me about informal arrangements in the province in China that he studies, specifically older women who go to market on the same day together, play cards on another same day together. And I'm sure those support networks are beneficial to their mental health, to their physical health, to ensuring their access to food security and other health devices. And I'm certain that parallels exist around the world. And while I'm not letting governments off the hook for their obligations, I think it's important for us to consider and be innovative and creative on alternative or supplemental community services and how, whether it's peer-to-peer support or intergenerational support, we can provide a better life for those of us who are older. So those are my short thoughts, and I'm grateful to be with you today, and I look forward to hearing questions and answers.
Thank you very much, Professor Stein. You always enlighten the discussion. Now I will give the floor back to the speakers for maximum 2 minutes, please, because we have received some questions from the floor. So I will start with Dr. Mitra. Lately, we have heard about green economy, blue economy, and recently about silver economy, which is the term being used to refer to the importance of the role of older persons in economy, not only as beneficiaries, but also as their motor. How the idea of including older persons as key actors of economy, including for health investment issues, could be more appealing for governments and other stakeholders. Please, you have the floor.
Okay, thank you so much. No, that's a really important question. I think older persons play a really important role in the economy, but it's a role that is often an invisible one. because it's not monetized. So for instance, providing care for grandchildren, for instance, is a really important role that facilitates the economic lives of working, middle-aged and younger adults, perhaps, but it's not monetized and therefore is not accounted as part of official statistics. I think moving away from traditional indicators for the economy, such as income per capita, GDP per capita, and considering more holistic indicators around perhaps, globally, perhaps you can think of them in terms of the well-being of our citizens, could incorporate such important roles that older people play. So I will limit it at that. I think there is a lot of work to do in terms of highlighting and making visible the important role that older people play, not only through their work, as Jody mentioned, a lot of them do continue to work, but also indirectly in supporting economic activities, often in unpaid ways.
Thank you very much, Dr. Mitra. And please, Dr. Hyman, if you want to share your thoughts in this regard, maybe you can do a mixture with the question that we have prepared for you, which is related to the lessons learned from the pandemic regarding access to health and social care services for older persons who were key actors in the framework of the pandemic. Thanks.
Great. Yeah, so let me first build on what Sophie said, and I certainly completely agree. There's an enormous amount of unpaid care work by older persons. We have the data across countries. It's done by people of all genders, but it is disproportionately done in numbers by women, for spouses, for parents, both disproportionately in how many do it and how intensively, how many hours. So including the economic productivity of that would be invaluable. I do want to add to that a comment, though, about the part of the economy that is captured in GDP, because there is a really important element there. There's great studies demonstrating the amount of bias and discrimination against older workers. So they are thought to be less productive. They are thought to be less good at adopting technology. There are a whole series of things. There are also studies looking at, is this true? So it turns out, no, it's not true on productivity. Whether if the productivity definition is, you're not only getting things through a manufacturing line, but you're getting it done accurately, or you're a high-skilled professional and both your productivity and your accuracy is incorporated in the measure, older people tend to be more productive because of the higher accuracy rates. So older people also adopt technology at much higher levels in the workplace than the bias assumes. So I do think there is a silver economy, both on the unpaid care work side and on the paid work side. In terms of the pandemic, what did we really learn? And I want to build on what my colleague Michael said, to say congregate settings did really badly during it. And the less engagement of families, the less well they did. So who did well during the pandemic, both in terms of care and in terms of social supports, because there was a pandemic of loneliness and mental health issues. It was people who had access to family supports. Laws matter to that. Policies matter to making that possible, as do the kind of peer-to-peer and intergenerational supports that can be stacked on top. Thanks.
Thank you very much, Dr. Hyman, for your comment and insights. Now, I would like to present the next question for Ricardo from UNHCR. At your webpage, you have quoted a thought from a Syrian refugee in Lebanon. You know, without the help of UNHCR, most of us could starve here, she says. But you need more than just a box of food. You also need interaction with other people, so you know you are still a human being and not just a number. So, how different stakeholders can support the initiatives on health and social care services of the office to make visible the needs and strengths of refugees, in particular older persons who could even face more challenges compared to refugees of other generations. For raising awareness in this regard, what is the impact of disaggregated data, such as the one you mentioned in your presentation? Please, Ricardo.
Thank you. Thank you for this question. And well, the type of communication or the type of content that external websites sometimes have do not have a clear objective in terms of, or they have a clear objective in raising awareness, but it's challenging as well in terms of the type of approaches that may follow. And I'm very honest in this. There is always room for improvement, and the type of messaging that is being shared there is not always the one that we encourage to use from the Division of International Protection. The lines that I think that are more important would be in line with what Dr. Heman and Dr. Mitra have been sharing in terms of considering that older persons can as well and do contribute to their societies. They are not passive recipients of aid, and they are actually an added value in terms of keeping the memory of their culture in displacement. They have often faced other situations of distress, and they have coping mechanisms that they can share with younger generations. And we have seen that recognized in some efforts. For example, coming back to the Global Refugee Forum, well, there were not many pledges or commitments in the last Global Refugee Forum encouraging or focusing on older persons. There was one, for example, from Thailand in providing citizenship for older persons who didn't have a citizenship in their countries, or stateless, combating stateless, in particular for older persons who may have not been registered at birth or were belonging to communities who were not acknowledged in the past as citizens. But we had, for example, a very good commitment from Norway in terms of socioeconomic inclusion and including as well opening avenues for employment, which focused as well on older persons. So it is a type of practice that can happen, and that again is not formally acknowledged in data, but it is there. There is in terms of data in particular, there is an additional challenge to this. So we have the challenge of higher disaggregation. So being unfair in terms of having a 60+ cutoff. I always say to my colleagues, would you have a 0 to 30 cutoff, 30 years old cutoff? That would be absolutely unfair, right? Because you have very different evolving capacities in that cohort. Well, it cannot be absolutely comparable, but somehow similar. There could be as well. There are higher capacities in the lower cutoff in the 60 years old, and lower needs required, while then there's an incrementing or exponentially incrementing need for support as we grow older. This is an issue, but there's a second issue, and it's that becoming older in certain societies, and in particular in displacements, those features are sometimes taking place in advance. So we may have societies with very low level of life expectancy, or the impact of displacement, in which we may observe the features, the characteristics of aging already in the 50s. So we have another problem there to solve in terms of having an aggregated or a cohesive way of understanding data. And I don't think that we have to be strict there. We need to be rather open and trying to visibilize those factors. Thank you.
Thank you very much for your answer to the question, dear Ricardo. We appreciate it. And now, please, Professor Stein, if you want to react to any of the questions posed so far. So after you, we can continue with Madame Nisrim before closing the event.
I'd much rather hear from Madam Nisrin, but my thought is that we need to innovate and to consider that we have this older population increase not as some kind of a mistake or some kind of a burden, but rather because we have addressed properly many illnesses, developed many medications, many other things. And so we ought to look at this population as well as an opportunity. Much of the dialogue that I've heard has been, not here today, but much of the dialogue that I hear has been looking at it as an approaching and encroaching problem, and the demographics are very clear. But it also can be an opportunity to rethink the way that our social structures are run. And I think we need to consider that very carefully as we go forward. For those of us who will continue to work on the development of the treaty, we have a lot of work to do, and especially within my little world of trying to think about the similarities and the differences that we can draw between aging and disability, and where the overlaps are helpful, and where the lack of overlaps are also helpful for targeting programming and thinking cleverly about moving forward.
Thank you, Professor Stein. Now, please, Madame Nisrin, what are the most common challenges that NHRIs from different regions face towards promoting access to health and social care services for older persons? Please, the floor is yours. You are muted.
Yeah. Thank you for all. I want to share my colleague about our focus on the point I focus on, and indicate all the challenges and barriers that face the old person. In different region here in Iraq, and consider if old person or a normal person in his young age, there's some obstacle and changes against human rights and all rights, because first of all, it's a norm or item of human rights, a problem for the government to accept and to take care of this item. So the matter, it's affected on the older person need the same, or maybe we can say it, more the rights that the normal people need, because when they became aging, many things need to do. They have no ability to take care of themselves, and also some old person, because their family or the society not need to be them, so they have no shelter to go, and sometimes have no money to go to the hospitalities or to go to doctors, can give the money to take treatment or whatever. So our ministries here in Iraq, the related one to the old person, like the Ministry of Labor and Social Affairs, have net protection for the old person. But not all the old person in all region in Iraq have the same service or can reach or easy to go to this ministry and to submit their document or their papers that they say we need to have some amount of money to live in, or we need some guarantee or social guarantee when we need to go to hospitality or we need to go to doctor that support us and the money that to treat us. So the challenges of the older person have many obstacles and need the offers, really offers from the government or from the countries that want to have the special agreement for them to support them or to offer them this special convention to protect or to somehow say to keep their dignity, not or keep their humanity. So we must take steps, really steps, to make these articles or convention to be real and a fact of our society. Thank you.
Thank you very much, Nisreen, and thank you all for your patience. We are aware that the event was planned to finish at 5 p.m. Geneva time, so we are truly grateful for your time. Before closing this event, by using the same channels of previous events, we warmly invite you to the 5th and last event of our series this year. It will be on access to cultural and leisure activities, tackling individual interests and intergenerational social construction. This will be held on the 23rd of November at the same time of today's event. So thank you so much once again, and we hope to welcome you again in the near future. Take good care.